Hello friends, we are in a series of lectures on controversies in the management of clinically N0 neck in oral cancer. In our previous video, I discussed first controversy, that was skip metastasis in oral cancer. We saw there and proved that skip metastasis is extremely rare. Today I am going to deal with second controversy, imaging to detect cervical nodes. Dear friends, let us pause for a moment and ask ourselves a very critical question. Is there any medical imaging which is truly reliable for picking up hidden cervical nodes? I am talking about a clinically non-palpable neck in a patient with oral cancer, clinically N0 neck. The search for the perfect scan has always been a great mystery in our field. Now we are going to dive deep into the actual evidence behind our imaging tools. We will look closely at their real accuracy rates and learn the absolute best practices for the N0 neck. Prepare yourselves because what we are about to see is truly exciting. Let us talk about the greatest illusion in head and neck oncology. Look carefully at the definition of a clinically negative neck. We call it clinically negative neck, meaning CN0, when there are absolutely zero detectable lymph node metastases despite a good neck palpation and imaging. That means you palpated the neck, you felt no lymph nodes, and then you did imaging, and there also you did not find any significant node. It is very tempting to celebrate and tell the patient, oh wow, your neck is free of cancer and you are completely safe. I will do a good surgery for your primary tumor only, and you will achieve long-term control and cure. But I want you to look here. Even in early oral cancers, the incidence of occult or hidden lymph node metastasis is a staggering 20 to 30%. What does occult or hidden lymph node mean here? It means if you do neck dissections in 100 patients who have apparently no nodes on palpation and on imaging, you will get the histopathology report showing one or more nodes having cancer cells in 20 to 30% of patients. This means that in nearly 1 out of every 4 patients with a perfectly normal looking neck, cancer cells are already hiding deep inside those nodes. And this is a huge number. This is the greatest illusion in head and neck cancer management. Listen, the reality is our hands and our imaging are simply not enough to catch these microscopic positive cells. If you do surgery for primary and don't treat neck now, thinking there is nothing in the neck clinically, these 20 to 30% patients will soon come up with nodal recurrence. Let us now move forward and understand how to assess a neck in a patient who presented to you with oral cancer. Now that we understand the high risk of hidden disease in the neck, how do we actually evaluate this clinically negative neck? This is evolution of various tools over time we developed to check neck nodes. Everything must always begin right at the patient's bedside. We started with a thorough clinical examination and careful palpation of the cervical nodes. But we soon realized that our hands alone will badly miss those microscopic cancer cells. Then we started using ultrasound neck. This simply means performing a dedicated ultrasound of the neck. but there were a lot of problems in doing ultrasound. We will discuss all those. Then we felt a need to look much deeper into the complex anatomical structure within the neck. We moved to advanced and metabolic imaging. We started utilizing these heavy machineries to look for neck nodes. We started with CT scan, then moved to MRI, thinking it will be better than CT, and then finally PET CT scan. However, we soon realized that even these most expensive imaging tools have their own pros and cons. This harsh reality brings us to the fourth and most definitive step of our assessment. The ultimate truth in oncology always lies in surgical pathology. To avoid unnecessarily radical surgeries, we are now using highly targeted surgical staging techniques. The most exciting advancement here is the sentinel lymph node biopsy, which we commonly call SLNB. Let us now break down each of these four steps to understand their true accuracy and their clinical limitations. Let us start with the very first tool to check if a patient has any node. This is the bedside clinical examination, neck palpation. Palpating the neck with our own hands remains the fundamental first step for evaluating any patient. But as we just discussed, our hands have very serious limitations. Routine clinical palpation only has a sensitivity of 60 to 70%. This means a very substantial proportion of hidden metastases will completely escape palpation. Why is our clinical examination so unreliable? There are three major factors that reduce the accuracy. First is the actual experience of the examiner. It really makes a difference if the neck was palpated by a beginner or an experienced surgeon. And for precisely this reason, you were taught and you will be taught how to examine neck. Second is the patient's body habitus. Because feeling a small 1 to 1.5 centimeter node in a thick or obese neck is extremely difficult. And third is any previous treatment like a past surgery or radiation therapy, which makes the neck tissue very hard and stiff. Because we cannot trust our hands alone, we are forced to move to some imaging. Since our clinical examination is clearly not enough, we must now rely on some sort of imaging. The first in the list is ultrasound of the neck. This is how ultrasound neck is done. You can see a radiologist holding an ultrasound probe against the patient's neck. Just below the probe, there are downward pointing arrows labeled with the numbers 1, 2 and 3. Ultrasound is done in a systematic step-by-step scanning process, starting from superior to inferior, sliding the probe. We heavily use the ultrasound because it is completely non-invasive. It is widely available and it is very cost-effective for our patients. We have been hearing doing ultrasound of the abdomen and pelvis since many decades. You can almost always see all the organs of the abdomen and pelvis. But what exactly is the radiologist looking for when they do ultrasound of the neck? They look for the small neck nodes which could not be palpated. But a normal person already have benign or some inflammatory neck nodes which require no treatment. How do metastatic nodes look different from those benign and inflammatory nodes? There are 5 major criteria that make a lymph node highly suspicious for it being metastatic. First, they look at the size, specifically a short axis diameter of more than 8 to 10 millimeters. Second, they check the shape. A malignant node tends to become round rather than oval. Third is the absence of an echogenic hilum, which means the normal fatty center of the node is destroyed. Fourth is a heterogeneous echogenicity, showing an irregular texture inside the node. And fifth, they use Doppler to look for peripheral or chaotic vascularity, which indicates abnormal blood flow. Remember all of these criteria you will be asked in exams. When we find these features, we can be highly confident that the node we are seeing in ultrasound is metastatic. As you can see, the basic ultrasound gives us a wide sensitivity of 63 to 97% and a specificity of 74 to 100%. If we combine this scan with the fine needle aspiration cytology or FNAC, we can boost our diagnostic sensitivity to 73 to 98%. However, friends, we must be very aware of the dangerous limitations with this imaging tool. A major problem is that ultrasound is highly operator dependent, meaning its accuracy relies entirely on the skill and experience of the person holding the probe. Also, its sensitivity drops drastically for very small metastatic deposits that are less than 5 mm in size. Because of these severe limitations, an ultrasound alone cannot give us a definitive guarantee of a truly safe neck. We just learned that a basic ultrasound has some limitation in evaluating neck. So you might logically think, why not just insert a needle and perform an ultrasound guided FNAC if you see a doubtful node? Please look carefully at the data on your screen from a very important prospective study. This study was conducted by Dr. Chaturvedi sir and his team at the Tata Memorial Hospital in Mumbai. They evaluated this exact technique in early stage oral cancer patients who had a clinically negative neck. The results of this study were a real eye-opener for surgical community. A regular ultrasound alone showed a very poor sensitivity of 50%. But surprisingly, when they added the guided FNAC, the sensitivity crashed down to just 14.3%. This means the needle completely missed the hidden microscopic cancer cells most of the time. It is true that if the guided FNAC comes back positive, it has a 100% specificity and a 100% positive predictive value. If the pathologist sees cancer cells from your needle sample, you can absolutely trust that finding. Obviously, you will not doubt how the cancer cells look different from a normal cells. But remember, our biggest challenge in an N0 neck is knowing when it is truly safe to leave the neck alone. The negative predictive value for the ultrasound guided FNAC was only 76.5%. This is not high enough. This tells us that even if your FNAC report is completely negative, there is still a huge chance that the cancer is hiding there. Not because the pathologist missed cancerous features of cell, but because the FNAC needle did not target the precise spot. Therefore, due to its profoundly poor sensitivity, ultrasound guided FNAC has absolutely no role in detecting occult metastasis in early oral cancers. We simply cannot risk our patients' lives on a diagnostic test that misses the nodes so frequently. We never do this procedure. Let us move on to the workhorse of our surgical planning, the CT scan. We always insist on getting a contrast-enhanced CT scan or CECT before taking any patient to the operating theatre. When we look at these scans, we are searching for very specific metastatic features inside the node. A highly suspicious node will have a size of more than 10 mm in its short axis diameter. We also look for typical radiological signs such as central necrosis, irregular enhancement, and the loss of normal fatty hilum. Remember these 4 criteria for your exams. You will be asked in your exams. If you look at the diagnostic performance of CECT, the sensitivity varies widely from 52 to 88%. Specificity is much better, 88%. Let us break down these exact numbers into practical clinical reality. I know many of you won't understand what this sensitivity and specificity means. When we talk about a sensitivity of 52 or 88%, we are talking about the CT scan's actual ability to catch the cancer when it is truly there. Imagine you have 100 patients who actually have hidden cancer cells inside their neck nodes. The CT scan will only successfully pick up the cancer in 52 to 88 of those patients. This means it will completely miss the cancer in anywhere from 12 to 48 patients. It will falsely report that their neck is perfectly clear when it is actually harboring it. This is a very dangerous false negative rate for an operating surgeon. This wide and unreliable sensitivity is exactly why a negative CT scan report never gives us the absolute permission to just leave the neck alone. Now let us look at the specificity of 88%. Specificity tells us how good the scan is at correctly identifying a truly healthy cancer-free neck. If 100 patients absolutely do not have any nodal metastasis, the scan will correctly report normal nodes in 88 of them. It will only give a false alarm in about 12 patients, confusing things like reactive or inflammatory nodes with actual cancer. So what is the final clinical lesson we must learn from these numbers? If the CT scan shows a suspicious node, we must take it very seriously because the specificity is quite reliable, 88%. But if the CT scan tells you the neck is totally clear, you simply cannot trust it. The poor sensitivity proves that CT scan is practically blind to those tiny micrometastases we are so desperately looking for. Now you must be asking why then CT scan remains our pre-operative standard. Why did I say it is a workhorse for evaluating head and neck cancer? It provides us with a massive clinical edge because it can easily see what our hands cannot feel. It is not much user dependent, unlike ultrasound. You see, I see, or someone else sees, the chances are quite high that we will report same for neck nodes. Also, it is absolutely ideal for evaluating deep cervical nodes, particularly level 2, 2B and retropharyngeal region. These deep anatomical areas are extremely challenging to assess clinically or even with an ultrasound probe. But we must be very careful because machine of CT scan is expensive compared to ultrasound. Also, CT has limited accuracy when it comes to detecting tiny micrometastases. It also struggles to catch early extracapsular spread, especially inside very small lymph nodes. This simply means that a radiologically clear CT scan does not ever guarantee a truly safe neck. Don't trust CT scan reports saying no significant cervical lymphadenopathy. You must treat neck. Let us now shift our focus to another very powerful tool to assess neck for cervical nodes: MRI. We all know that MRI is famous for providing absolutely excellent soft tissue contrast. When we evaluate the neck with an MRI, we rely on general criteria like the size and the shape of the lymph nodes. We also look very carefully for signal heterogeneity and early signs of extracapsular spread. But again, we must look at the actual diagnostic reality of these numbers. The data shows that MRI has a sensitivity ranging from 65 to 95%. Let us understand what this truly means. If 100 patients actually have microscopic cancer cells hiding in their neck, the MRI will successfully find them in 65 to 95 of those patients. This means it can completely miss the cancer in up to 35 of patients. This is dangerous as like CT scan. Now please look at the specificity, which is shockingly wide, ranging from 40 to 94%. Specificity tells us how good the scan is at correctly recognizing a truly node-negative neck. This means if 100 patients have a totally node-negative neck, the MRI might falsely report suspicious nodes in up to 60 of them. It very frequently gets confused by simple, harmless, reactive or inflammatory lymph nodes. We saw this similar problem with CT scan. So, a basic MRI can lead to many unnecessary neck dissections due to false alarms while still missing the very tiny disease. To fight this exact problem, radiologists are now using very exciting advanced technique like DWI and DCE MRI. DWI means diffusion weighted imaging. ADC means apparent diffusion coefficient. In these techniques of MRI, metastatic nodes will show restricted diffusion of water molecules and much lower ADC values compared to benign nodes. We also use DCE MRI to carefully evaluate the abnormal blood perfusion parameters inside a malignant node. DCE means dynamic contrast enhanced MRI. But despite all this wonderful and expensive technology, please look at the problem with them. Even with these highly advanced functional techniques, the MRI still struggles to detect tiny micrometastases, just like CT scan. Once again, we are left searching because even the MRI cannot perfectly guarantee a safe and cancer-free neck. Let us finally examine the most advanced and expensive imaging tool we have today, PET-CT scan. See, the standard CT and MRI scans we just discussed mainly look at the physical anatomy of lymph node. They essentially wait for a lymph nodes to grow big or change its physical shape before calling it suspicious. But the PET CT scan is completely different because it is a highly advanced metabolic scan. In PET CT, we inject a safe radioactive sugar known as FDG into our patient. Because cancer cells are rapidly dividing, they are extremely hungry and they quickly eat up the sugar. Due to this high sugar glucose uptake, the hidden malignant nodes literally light up brightly on our computer screen. See here. This brilliant technology allows us to identify dangerous metabolic abnormalities long before any physical or morphological changes become apparent in the lymph node. But does this theoretical advantage translate into any clinical benefit? See this very latest data on your screen. This is from a massive 2024 comprehensive meta-analysis by Goods and his colleague. They evaluated nearly 2,000 head and neck cancer patients. They confirmed that the baseline prevalence of hidden occult metastasis is around 23%. How good the PET CT scan is at detecting this hidden disease in the neck? The data shows that its overall sensitivity is only 71%. If 100 patients actually harbor microscopic cancer cells in their neck, the PET CT will successfully light up and detect them in only 71 of those patients. This means this highly advanced machine will completely miss the cancer in 29 patients. That is 29 patients who will be falsely told their neck does not have any nodes. This is unacceptable and dangerous. Now let us look at the specificity, which is very impressive, 90%, better than CT and MRI. If 100 patients have a truly node negative, PET CT will correctly remain silent in 90 of them. It will only give us a false alarm or light up unnecessarily in about 10 patients. This is a good thing about PET CT. You will also see a very high negative predictive value of 92% on the screen. Negative predictive value tells us how much we can trust a completely negative scan report of PET CT. If the PET CT scans reports absolutely zero signs of cancer, there is a 92% guarantee that the neck is truly safe and cancer-free. 8% patient will still have microscopic nodes not picked up by PET CT. At first glance, a 92% guarantee sounds excellent, isn't it? But friends, please do not let these high numbers give you a false sense of security. Look at the final verdict about PET CT for neck assessment. Because the sensitivity is strictly stuck at 71%, the false negative rate remains dangerously high. Therefore, we can never safely use a negative PET scan as our only reason to omit a neck dissection. So you saw how our most advanced technology, including CT scan, MRI scan, and even PET CT scans, cannot replace the ultimate safety of a neck dissection. Let us now understand exactly what this powerful PET CT can do and where it fails. Look at its major clinical capabilities. We already know that it gives us an excellent systemic upreach. This means we can evaluate the regional neck nodes and check for distant metastasis exactly same time. It also provides us with a very early warning through early detection. Because it looks at the actual glucose uptake, it identifies dangerous metabolic shifts long before the lymph node changes its physical shape. But this is where the real danger lies. The PET-CT has very strict spatial limits. It struggles to see any hidden metastatic deposits that are less than 5 mm in size. This blindness happens due to its limited spatial resolution and partial volume effects. Also, the PET-CT carries major specificity risk. It is highly vulnerable to giving us dangerously false positive alarms. The scan will frequently light up brightly or for simple inflammatory or infectious processes. This is exactly why we must always correlate these expensive scans with our basic clinical judgment. Let us now look at a very important study called Acrine 6685 trial. This is a busy slide with lots of numbers. Please pay attention. This is a newer study published a few years ago that specifically evaluated the PET-CT scan in the clinically N0 setting in head and neck cancer. It prospectively enrolled 287 patients from 23 different American College of Radiology institutions. The researchers carefully analyzed these scans and pathology findings for 270 clinically negative neck sites across 212 participants. Let us look at their diagnostic results. Based on a standard visual assessment, the negative predictive value was pretty high at 86.8%. But they found that if you adjusted with the SUV value, this predictive value would go even higher. When they used a cutoff of just 1.8, the negative predictive value jumped to a fairly high 94.2%. This scan also had a major impact on actual surgical planning. The clinicians were initially blinded to perfect PET's report. That means they were not told about the findings of PET-CT initially. They were asked to propose their treatment plan. When they were finally informed of the PET results, it resulted in a 22% change in the overall treatment plan. Overall, the true negatives were 87% and the false negative rates were 13%. Now we must ask ourselves a very serious question based on this data. Does this make the PET-CT robust enough to safely guide us in the N0 setting? My answer to you is big no. The biggest problem here is that they have not really looked at the clinical outcomes of these patients in this trial. You can see that the true negative rate is 86 to 87%. That means in 1 in 5 patients, you have a major treatment plan change. They have not looked at any survival results. They have also not looked at how much disease recurred or what salvage treatment these patients ultimately received. Therefore, we must accept our current clinical reality. As of today, it is appropriate to say that we will definitely have better advances with various radiological investigation in the future. But at this point in time, we do not have any imaging tool in our armamentarium that is able to perfectly diagnose an occult metastasis in an early oral cavity cancer. We saw there was a problem with palpation, ultrasounds, CT scans, MRI scans, and even PET-CT. So do not trust any imaging. Go ahead and do elective neck dissection to get a true pathological nodal staging. Now, best thing would have been to compare all these 4 imaging modalities as head-to-head comparison on same patients. That means you do ultrasound, CT scans, MRI and PET-CT on every patient and then do comparison. Is there any such study done so far? Luckily, we found this study published in 2024. This is a meta-analysis published by Al-Sibani and colleagues in 2024. They did a direct head-to-head comparison between all 4 modalities to see which is best and can the best replace neck dissection. They evaluated a massive cohort of nearly 4,000 head and neck cancer patients. Their goal was to finally determine which of our imaging modalities is actually the best for evaluating a clinically N0 neck. As you can clearly see, the PET-CT scan emerges as the overall winner. It gives us the highest sensitivity at 74.5% and the highest specificity at 83.6%. It also boasts the highest diagnostic odds ratio of nearly 15.5. Now look at the same values for a simple bedside ultrasound. Surprisingly, it performs quite well, taking the second spot with a sensitivity of 70.5%. Our routine CT scan drops down to a much lower sensitivity of 64.1%. And the MRI performs the poorest for finding these hidden nodes with a sensitivity of just 59.1%. But dear friends, what is the ultimate clinical lessons we must take away from this entire chart? Even our absolute best modality, the expensive PET-CT, still misses the occult disease in over 25% of our patients. This means 1 in 4 patients will be given a false guarantee of safety. Therefore, our surgical conclusion remains exactly the same. No single imaging scan currently possesses the diagnostic power to safely replace an elective neck dissection. So here is the middle path between an elective neck dissection and simply wait and watch strategy. Let us talk about a much less invasive option called sentinel lymph node biopsy or SLNB. The basic idea here is very simple. We only want to find and remove the very first lymph node that drains the tumor. It is called as sentinel node. If this first node is completely free of cancer, we can safely assume that the rest of the neck is also negative for neck metastasis. How do we actually do this in our operation theatre? We select patients with early oral cancer who have clinically node negative neck. Before the surgery, we do a scan called lymphoscintigraphy. We inject a safe radioactive tracer and often a blue dye right next to the oral primary tumor. Then during the surgery, we use a handheld gamma probe to find that specific node and remove it. But taking the node out is just the first step. The most important work happens in the pathology lab. The pathologist does a very detailed check to find any hidden microscopic cancer cells. They use a serial sectioning to cut the nodes into many very thin slices. They also use special stains called immunohistochemistry or IHC to easily identify the cancer cells. Many good centers also do a multi-slice frozen section right during the surgery itself. This helps us find tiny micrometastases before we even close the patient neck. Now please look at the numbers for this procedure. The combined data shows a very good sensitivity of 87 to 93%. More importantly, the negative predictive value is an excellent 94% to 96%. This means if the sentinel node is truly negative, you can be highly confident that the patient neck is node negative. Finally, we must respect the massive contribution of Japanese colleagues in this field. Dr. Terada and his team have done a great work on this. They published major studies from 2005 to 2010. They proved that SLNB is highly accurate and practical for oral cancer. They also showed how to perfectly use the frozen section technique to make this a safe one-stage surgery. These exact studies have given us a very strong and reliable alternative to the standard elective neck dissection. However, here also there are problems with SLNB. We will discuss all those when we will do a separate discussion on it. Let us now summarize everything we have discussed today. This is a very important summary table. We already know that the clinically N0 neck has a 20 to 30% chances of hiding occult metastasis. Because of this high baseline risk, we desperately need an imaging test having close to 100% negative predictive value to safely avoid a surgical neck dissection. But no current imaging modality can achieve this perfect score. Let us look at our diagnostic images to understand exactly why every single test ultimately fails us. First, we have basic clinical palpation. It only gives us a limited sensitivity of 60 to 70%. Its fatal flaw is a dangerously high false negative rate. This error rate changes constantly because it is heavily influenced by the patient's body habitus and the examiner's own subjectivity. Next, we look at the simple ultrasound and ultrasound guided FNAC. The sensitivity here is profoundly poor at just 50% for a basic ultrasound. It drops to an even worse 14.3% when we add the guided FNAC. This test is simply too operative dependent and completely fails to detect true occult disease. Then we move to CT and MRI scans. They give us a somewhat better sensitivity of around 81%. But they are completely unreliable to reliably differentiate a harmless reactive hyperplasia from a deadly micrometastasis. They rely too much on basic and morphological criteria like size, central lucency, which simply cannot catch early cellular spread. Finally, we arrive at our most advanced machine, PET-CT scan. It gives us a sensitivity of 71% and a good specificity of 90%. But its fatal flaw is a strict physical limitation. Due to partial volume effects and limited spatial resolution, the PET-CT is guaranteed to miss tiny micrometastases that are less than 5 mm in size. So this table proves that the safety offered by these imaging scans is nothing but a dangerous illusion. Don't fall for it. So if all our modern imaging machines fail to give us a perfect guarantee, what should we do for a neck in a clinically negative neck for our patients? Please look at this comparison. On the left, you see our entire armamentarium we have in our hospitals to detect neck nodes. From basic clinical palpation to the most expensive PET CT scans, every single modality is fundamentally imperfect. They are completely unable to perfectly diagnose those tiny hidden occult micrometastases. This brings us to a very strict surgical rule. You simply do not trust imaging alone when there is a question of patient's life. This is why the surgical blade remains our ultimate truth teller. Elective neck dissection is still the absolute gold standard for managing the clinical N0 neck. Surgery physically removes the danger and gives our pathologists the tissue they need. It is the only method that provides true pathological nodal staging. So what is the final conclusion we must accept today? We must go ahead and perform an elective neck dissection to secure accurate staging and guarantee our patient's safety. Let us conclude our discussion by looking at this final, very powerful message. On the left side, you see what we call a radiological shadow. No matter how advanced our scans become, they are fundamentally limited by their spatial resolution. Because of this, imaging will completely miss the tiny disease that is less than 5 mm, leaving dangerous micrometastases behind in our patient's neck. Now see the right side, which allows our ultimate pathological reality. This provides us with a definitive staging at the absolute cellular level. More importantly, the surgical blade physically removes the lymph nodes and completely clears the occult disease. This brings us to the most important clinical verdict of our entire presentation. Based on the landmark randomized trial data, we know that an elective neck dissection delivers a proven 12.5% absolute benefit in overall survival. Therefore, friends, an elective neck dissection remains the undeniable gold standard for safely managing the clinically N0 neck in early oral cancer. With this, I finished the second controversy in the management of clinically N0 neck. In my next video, I will take third controversy, elective neck dissection versus therapeutic neck dissection. Thanks for watching. Stay tuned. See you in next video. Signing off, Parveen, Ahlawat.